Okay, so the next part for the GI series for the pants, of course, this is following along the NCCPA blueprint for the pants. It's going to be focusing on esophageal disorders. Made this a 1 of 2 part series because there's a lot in the esophagus and I didn't want to pack it all into one video and make it too long. So today, the first part is going to be going over esophagitis. That involves infectious, eosinophilic, pill-induced, and caustic. And then GERD, achalasia, distal esophageal spasm, and hypercontractile esophagus, also known as jackhammer esophagus or Nutcracker esophagus. So those are the ones we'll go over today. These are pretty important topics, and let's get started. I always like to mention, though, if you do like the content on YouTube, I also have a podcast as well under the same name, Cram the Pants. You can find it on Spotify and Apple Podcasts if you wanted to listen to that as well. So let's get started. We'll start with esophagitis. Now, overall, this is the most common cause of esophagitis is going to be GERD, but there are some other causes that we'll go over as well. And all it is an inflammation or irritation of the esophagus from a number of different causes. Again, like I said before, most common cause is GERD, which we'll go over that next. But there's a few other causes that you need to know as well, and that's going to be infectious, eosinophilic, pill-induced, and caustic or corrosive. So those are the ones there that we'll go over now. There's not a lot you need to know about this. There's only a few things for each, so I'll make it kind of brief, and they all are pretty similar as far as presentation and diagnosis. So patient presentation, almost all of these are going to present the same way. Adenophagia, which is pain with swallowing, and dysphagia, which is difficulty swallowing. Across the board, they're all going to present that way for the most part. And then diagnosis is going to be endoscopy for all of them. So pretty easy with that. Otherwise, you just need to know a few things. So let's start with infectious esophagitis. So infectious esophagitis is caused from infectious organisms. So Candida, HSV, CMV, and your patient with infectious esophagitis will almost always be immunocompromised. This is not something that you're commonly or really ever going to see in a healthy patient. So these patients are going to have HIV, undergoing chemo, malignancy, whatever it is, they're going to be immunocompromised. So this normally isn't going to be seen in a healthy patient. As far as the most common cause of infectious esophagitis, that's going to be Candida. So as far as treatment, Candida, you're going to treat with fluconazole. That one's pretty easy because that's the same you treat across the board for Candida for the most part. Cytomegalovirus or CMV, you're going to treat with ganciclovir. And the way I remember this is ganciclovir sounds like gangcyclovir. Actually, that's the way I used to say it before I actually saw it spelled. And CMV, and this helps you because this isn't just CMV for esophagitis, but any CMV, your first line treatment is always going to be ganciclovir. So I remember CMV, ganciclovir, and then I remember gangs, and then I remember CMV caused mostly violence. So gangs cause mostly violence. Then you'll remember CMV. Your first line treatment is going to be ganciclovir. So that's how I remember that. And then treatment for HSV is acyclovir. So that's the treatment, the findings for infectious esophagitis. Not a lot to know here, but that is, the few things that you do need to know. Remember, Candida is going to be your most common cause. Moving on to eosinophilic esophagitis. So this is going to be a chronic allergic condition where you have this accumulation of these eosinophils in the esophagus, and it leads to inflammation, which can cause trouble swallowing, dysphagia. It's going to be most common in children with atopy or atopic disease, so children with asthma, eczema. That's where you're normally going to find this in. As far as the endoscopic findings, you're going to see something called stacked circular rings or corrugated rings, and that's exactly what they look like. So you're going to have these circular rings down the esophagus, and this is from the accumulation of the eosinophils in the esophagus. So that's the key finding you'll have in eosinophilic esophagitis. And then as far as treatment, there's a couple different things you can do. You can do using inhaled corticosteroids, but you don't use the spacer. Now, when you use inhaled corticosteroids for a pulmonary disorder, whether it's asthma, acute bronchitis if they have a cough, so or more so for asthma, you're going to use a spacer. And the reason you use a spacer is because it gives the patient more time to inhale the medication to get it into the lungs. Well, in this case, you don't want it to go into the lungs, you want it to go into the throat. So you don't use a spacer. It kind of goes to the back of the mouth and you have the patient swallow it. So a lot more information than you need to know. It's really more for clinicals in real life, but inhaled corticosteroids is normally going to be your first line, and then remove any offending agents that may be causing this allergic reaction. So there's food, medication, remove the offending agent. That's pretty much all you need to know for eosinophilic esophagitis. There's not too much to know there. And now Pill-induced esophagitis, there's almost nothing to know with this. It's really straightforward and common sense for the most part. It's really only one thing you need to know, and I'll tell you that in a second. So this is just esophagitis due to prolonged exposure to a medication. It's a patient who took a med, maybe didn't drink enough water, they laid down right after they took it, and it's just sitting in the esophagus, and it's causing irritation in the esophagus. So really, this is the only thing that you need to know for this. Everything else is common sense. So the most common meds, NSAIDs and bisphosphonates, so alendronate and those medications in that class. So that's what you're going to need to know for a vignette, because they're going to say what medication the patient most likely take that has this adenophagia now, etc. That's what you need to know. NSAIDs and bisphosphonates. Those are your most common meds to cause pill-induced esophagitis. So the endoscopic findings are really non-specific. You may have ulcers of varying depth depending on how long the pill was in the throat. And then treatment is very common sense. Just drink large quantities of water with the med. Normally they say about 4 more ounces, and then avoid recumbency for 30 to 60 minutes. So don't lay down right after you take a med. Drink enough water, and that's how you treat it. So again, it's common sense. Really, all you need to take away from this is that NSAIDs and bisphosphonates are going to be your most common treatment, or I'm sorry, your most common cause for pill-induced esophagitis. So that's that. Pretty easy. Caustic esophagitis, also known as corrosive esophagitis. This is going to be esophagitis due to an ingestion of caustic or corrosive substance, normally acidic or alkalotic agent. And in addition to adenophagia and dysphagia, this one is really the only one that the patient may have some more severe symptoms like hematemesis, dyspnea, because they have this. They may even have a perforation in the esophagus. So these patients can be really sick in some cases. Endoscopy is really not to diagnose, because you know what happened with this patient. You know, most of the time it's a child and the parents may have witnessed it or saw the whatever the substance was that they swallowed, but it really assess the extent of the damage. And one thing that I want to note here is that between an alkalotic agent and an acidic agent, normally your thought would be that an acidic agent would be the more damaging one, but it's actually alkalotic agents are actually much more dangerous than acidic. They're more likely to perforate the esophagus and cause deeper injury to the tissue. Acidic agents are generally repelled by the mucosal surface of the esophagus, where alkaline agents like sodium hydroxide, for instance, which is what's in drain cleaner, so that's an alkalotic agent, can actually cause a transmural esophageal necrosis within a matter of seconds. So alkalotic agents are much more dangerous, so drain cleaner in particular. So that's something that you need to know as well, because that's something for a history of a patient that's very important. As far as treatment, it's mostly going to be supportive, depending on how severe it is. Of course, if they have perforation in the esophagus, they're going to go to the OR, but supportive as long as it's not that severe, fluids, pain meds, and things like that. And another thing that's important to know is that these patients, when they present and you treat them, they're not necessarily in the clear. Really, you need to monitor these patients for up to 10 days, because the injured esophageal mucosal wall forms granulation tissue. And if you remember back to wound healing and things like that, granulation tissue initially can be particularly susceptible to tears and to breaking down of the tissue. So these patients can actually have a perforation up to 10 days out because of the healing process. So it's just important to know, really, when you get into real life and practicing medicine, that these patients need to be monitored for a period of time. So that's caustic esophagitis. Not a lot to know there. A lot of FYI things that I wanted to mention, though, that I feel like is important to know. So now moving on to something that is a little bit more information that you need to know, and that's GERD. So gastroesophageal reflux disease. There's a few things you need to know with this, and this is one that you'll certainly be tested on. All this is a reflux of your gastric contents, all the acid and the food into the esophagus due to a relaxed or incompetent lower esophageal sphincter. So just remembering your anatomy here, down here is your pyloric sphincter that goes into the duodenum, but we're looking up here at the lower esophageal sphincter. So normally this is pretty competent, it closes tight, and the acid is prevented from going back up into the esophagus. But a patient with an incompetent lower esophageal sphincter may have this weakened sphincter, and some of the gastric contents are able to go into the esophagus, which obviously causes some discomfort and heartburn and things like that. So history and exam, this is really straightforward. Everybody knows what heartburn is and GERD. It's also known as pyrosis. They may have a sour taste in the mouth from the acid coming up. They may have this nocturnal cough. A lot of times patients will come in and say, I'm having this cough at night. It only bothers me at night. During the day, I'm fine. And that's because the acid is going into the esophagus. They're having this irritation and they have this cough that's really only present at night. So those are the common symptoms you're going to see with GERD. Now, some of your alarm symptoms, things that are going to warrant an endoscopy and further investigation into these patients. It's going to be weight loss, adenophagia. They shouldn't really be having pain with swallowing. They may have some discomfort, but not normally pain. Bleeding and dysphagia, especially if it's progressive, because progressive dysphagia is normally going to point to an evolving mass. So if you have somebody who comes in and says, I was having some trouble swallowing. Normally it was like when I had steak or bread, whatever it is. And over the last few months, now I'm even having trouble swallowing from liquids. I'm having trouble with water. This is normally because there's a mass present and it's getting larger and larger to this progressive dysphagia. So that's important because that may be in a vignette and it's really important for real life as well when you're treating patients. So know that these are going to be your alarm symptoms. These are going to warrant a further investigation for these patients. As far as diagnosing, well, initially, most of these patients, it's going to be a clinical diagnosis. They're going to come in, they're going to say, I have heartburn, I have this nocturnal cough, sour taste in my mouth, whatever. Those type of symptoms, you're going to normally try do what's called a PPI trial. So you give these patients PPIs, omeprazole, lansoprazole, all of the common ones, the PPIs, give them for about 8 weeks. And at the end of 8 weeks, if they're still having symptoms, they're not getting any better, that's when you investigate a little bit further. But most of the time, most of these patients, after about 8 weeks, they'll start feeling better, and you diagnose your GERD clinically by their symptoms and the fact that it resolved with PPIs. Now, if this doesn't give you the answer you need it to, you move on to the next step, which is going to be esophageal manometry. So what this is, let me show you a picture here. So this is going to be a small catheter that's inserted into the nasal cavity, goes all the way down into the lower esophageal sphincter, all the way through the lower esophageal sphincter into the stomach here. Now this is a pressure sensitive tube, and it transmits data over 24 hours and indicates the strength or really the lack thereof of the lower esophageal sphincter. So you have this pressure sensitive catheter and it's through the lower esophageal sphincter. So over 24 hours, they can test to see if there's pressure in this area or if there's not. So a normal patient is going to have about 10 to 45 millimeters of mercury pushing from the lower esophageal sphincter. A patient with an incompetent lower esophageal sphincter, or a patient that potentially could have GERD, is normally going to have less than 10 millimeters of mercury. So that's how this test works. It's a 24-hour test. And that's going to be when you need a more definitive answer. Now, that's one way to test for GERD. Now, your gold standard, your best test by far for GERD is going to be 24-hour pH monitoring. So let me show you what that looks like. So 24-hour pH monitoring, again, is going to be your gold standard. Not always going to be done because this is a little bit more invasive. It's a little bit more expensive, but it's similar to manometry in the same way that you have a catheter that goes through the nose, but this time instead of the probe going into the stomach, it sits just superior to the lower esophageal sphincter. And what it does for 24 hours is measures the pH of the esophagus here. Now, in a normal esophagus, the pH is normally going to be about 4 to 7 because there shouldn't be acid present, so it shouldn't be that low. But in a patient with GERD, you're going to have this acid coming up, which obviously has a much lower pH, and you're going to start having these readings less than 4 pH, and that's going to indicate that there's acid present in the esophagus, and this will make the diagnosis of GERD. And there's also this little box here, and what these patients can do is when they're either laying down or they start to have the feelings of that pyrosis, that heartburn, they can press a little button here. So when they go over the 24 hours, they can see where these patients marked, okay, I started feeling heartburn here. They'll look at the graph and they'll say, okay, let's see what the pH was when they marked that they were either laying down or starting having symptoms. So that's how 24-hour pH monitoring works. And that's going to be your gold standard. That's your best test, your most expensive, but your best test for diagnosing GERD. In a refractory patient, one other thing that I wanted to mention for diagnosis, endoscopy is not really going to be something that's used really for GERD. It's really only going to be those patients who you've made the diagnosis, PPIs aren't getting them any better, or they have alarm symptoms. They're having that dysphagia, they're having adenophagia, they're having weight loss, then you go ahead and do an endoscopy. And it's really to look for other causes like cancer, of course. As far as treatment, initially, you're going to want to try lifestyle modifications. So weight loss, elevating the head of the bed, avoiding dietary triggers, eliminating alcohol and cigarettes. Alcohol and cigarettes can actually cause decreased strength of the lower esophageal sphincter, so they can lead to GERD. And then certain dietary triggers. So some of the dietary triggers are caffeine, chocolate, spicy, high-fat foods, peppermint. These can all delay gastric emptying and put more pressure on the lower esophageal sphincter. And peppermint, interestingly enough, the reason peppermint is given, if you go to a restaurant, I'm sure we've all seen mints at the end when you're leaving. They have mints at the front counter there. The reason they've given that over the years in history is because peppermint generally relaxes the digestive system. It relieves spasms in the gut. It can decrease peristalsis and just makes the digestive system a little bit more comfortable. But because it relaxes the GI system, it can also relax the lower esophageal sphincter, so it can actually lead to GERD. So that's just something that I felt is interesting to mention. So initially, lifestyle modifications. In real life, though, most patients that come in with these symptoms aren't going to want you to tell them lose some weight, stop smoking. Most patients want medication. So initially, most of the time, in a mild intermittent patient, that has less than 2 episodes per week, you're going to try either antacids or H2 receptor antagonists. So that's going to be famotidine, cimetidine. I mentioned a way to remember the class for H2 receptors in another video, but I remember tidine at the end. I think of, instead of tidine, famotidine, cimetidine, I think of tudine. So you go tudine, and after you go tudine, you have heartburn from dining and eating so much food. So that's how I remember this class of medication. The tidine, I just think of tudine, and that makes me remember H2 receptor antagonists. So that's going to be for mild intermittent cases. H2 receptor antagonists are okay medications, but really they can actually become, after about 2 to 6 weeks, many patients actually experience what's known as tachyphylaxis. And this is when a medication decreases in efficacy. So after about 2 to 6 weeks of using H2 receptor antagonists, a lot of times patients will start to have their symptoms return and the meds don't work as well. So if you try these medications and they're still having symptoms, or more severe patients that are having 2 or more episodes in a week, your best med by far is going to be your PPIs, your omeprazole and lansoprazole. And again, I went over this before, how these meds work, but they block the hydrogen potassium ATPase pump, so they completely shut down acid. Where H2 receptor antagonists are just blocking histamine, but you also have the histamine channel, but you also have acetylcholine and gastrin, which can also activate acid. So these don't work as well as PPIs. PPIs shut down the pump completely. So these are going to be your best medication. And after about 8 weeks in patients with GERD that use PPIs, about 86% of patients have a complete resolution of symptoms. And in fact, if PPIs don't work for your patients, after about 8 weeks, you're going to want to refer them to GI to see what else could be going on. So these are going to be your treatments. Initially, lifestyle modifications, mild intermittent cases, try antacids, H2 receptor antagonists, and then severe frequent symptoms, bring out your big guns, your PPIs. So that's your treatment. Now, if a patient is refractory, they've tried all these meds, they're not getting any better, there's one other option you have, which is obviously a lot more invasive, and it's a surgery known as a Nissen fundoplication. And what this is they take the fundus, which is the top of the stomach here, and they wrap it around the lower esophageal sphincter. They wrap it tightly, they suture it closed, and this actually tightens the lower esophageal sphincter, so it prevents that reflux. So again, this is obviously a procedure that you're only going to perform in patients that are refractory to all the other treatments that you've tried, because this is obviously a lot more invasive, but this is an option for those refractory patients, so you should know it. Moving on, we're going to go on to motility disorders now. Now, motility disorders are all going to present in a similar way. Motility disorders are going to involve achalasia, it's going to diffuse esophageal spasms, and then hypercontractile esophagus are your motility disorders. I just want to really briefly go over how you're normally going to see these patients present and how you're going to diagnose and treat. Almost across the board motility disorders, they're going to have dysphagia to both solids and liquids. As far as diagnosing, across the board is going to be esophageal manometry. And then treatment across the board is typically going to be calcium channel blockers. There are some exceptions I'll go over with achalasia, but I just wanted you to know that generally motility disorders, Patients are going to have dysphagia to both solids and liquids. You're going to diagnose with esophageal manometry, and you're going to treat typically with calcium channel blockers. I'll go over that exception in a minute. But let's start with our first motility disorder. That's going to be achalasia. And with achalasia, this is normally going to be the one that you see mentioned the most. This is just like the popular motility disorder that you're going to see on your exams and things like that. So achalasia is this esophageal motility disorder that there's a degeneration or damage to the Auerbach plexus. And the Auerbach plexus provides motor innervation to the esophagus. So if you have a degeneration or damage to this area, there's going to be a decrease or loss of peristalsis in the esophagus, and more importantly, there's this impaired relaxation of the lower esophageal sphincter. So food's getting into the esophagus, it's not getting pushed down, it's kind of sitting in the esophagus, and then even once it does reach the stomach, the lower esophageal sphincter is clamped shut. So these patients on history and exam, like I said, for all motility disorders, are going to have dysphagia to both solids and liquids. Again, this is going to present in all of them, so you need to know that. And the reason it's going to be to solids and liquids is because the esophagus isn't working the way it should. It's not pushing the food down. And you need to know if that in a vignette you only see dysphagia to solids, don't think a motility disorder. You're going to be thinking more of a mass or an esophageal stricture. Again, like I said before, masses can eventually evolve into dysphagia to both solids and liquids, but initially just to solids, and then esophageal strictures are normally just to solids. So remember, motility disorders like achalasia, dysphagia to both solids and liquids. And then they may have some other non-specific symptoms, regurgitation, weight loss, retrosternal pain and pressure, just due to the food being kind of caught in the throat and not being pushed down as well. So that's your history and exam. How are we going to diagnose this? Like I went over before, esophageal manometry is going to be your best test for all of the motility disorders. And in this case, what you're going to have with esophageal manometry, instead of, let's go back here real quick. So esophageal manometry in this case, now before when we were doing it for GERD, we put it through into the stomach to test the strength of the lower esophageal sphincter, or the lack thereof in GERD. Now, with achalasia, with esophageal manometry, the same catheter is going to be placed into the nares, into the nostrils, down to the stomach. And then what they're going to do, they're going to have it go all the way into the stomach past the lower esophageal sphincter. They're going to give the patient some food to eat. There's a couple different substances. Sometimes they'll give them crackers. Sometimes they'll give them like this jello-like substance. So they have the catheter in there, the pressure sensitive catheter, and while they're eating and swallowing, they're going to slowly pull the catheter up and out. And as they're pulling it up, they're going to test the grade of the muscle contractions at different segments of the esophagus. Now, a positive test is going to be a patient that has these esophageal aperistalsis, so no peristalsis noticed in that pressure-sensitive catheter, and it's going to have an incomplete relaxation of the lower esophageal sphincter, so it's just going to have this pressure continually on the lower esophageal sphincter. So esophageal manometry, again, is your best test. And then another option is going to be a barium swallow, also known as a barium esophagram. And you need to know that with achalasia, what you're going to see on this barium swallow or barium esophagram is something known as a bird beak appearance. Now, the Pance is not normally going to use these keywords, so they're not going to say a bird-like or a bird beak-like appearance, but they may say narrowed or tapered off at the lower esophageal sphincter appearing on barium swallow. So this is what this is. So you give a patient barium to swallow, they swallow it, and you have the nice open patent esophagus, but then once it gets to the lower esophageal sphincter, the LES is clamped shut. It's not opening. So you're only getting a tiny bit of barium coming through into the stomach. So you have this tapered off appearance. And if you look at this diagram here, it kind of looks like a bird beak because it tapers off into like a bird-like appearance. So you need to know that because for some reason, it seems like they love to ask about that bird beak appearance of achalasia. So remember that this isn't necessarily going to be your best test, but it is going to be something that they may test you on. So no bird beak-like appearance or tapered off appearance of the LES on barium swallow for achalasia. You're not normally going to do an endoscopy for patients with achalasia. It's really just to rule out if you suspect cancer or other causes of the dysphagia. So really it's going to be your esophageal manometry and your barium swallow. As far as treatment, Initially with achalasia, you can try calcium channel blockers. Nitrates work as well, Botox injections too, but Botox injections have to be repeated every 6 to 12 months. But now there's more definitive treatments, like I said. One of them is something known as a pneumatic dilation. This is going to be more definitive, but it often needs to be repeated. So what pneumatic dilation is, you're going to have this catheter that comes down that has this balloon that's going to be inserted into the lower esophageal sphincter. What they do is they inflate this balloon, and what it does is it stretches and weakens the lower esophageal muscles fibers. Normally needs to be repeated sometimes 2 or 3 times to achieve full resolution of symptoms, and sometimes this can persist. So this isn't going to be your best option, but it does work pretty well, and it's less invasive than other options. And the other option is something called a cardiomyotomy, also known as an esophageal myomectomy. So this is going to be your most definitive treatment, but also your most invasive. Normally it's done laparoscopically, but what this is, let me go back here. Okay, I moved forward. But so what this is going to be a procedure where the strength of the lower esophageal muscle fibers is weakened by actually cutting into the lower esophageal sphincter, breaking the tensile strength of these muscle fibers. So they cut into the muscle fibers and they weaken the muscle of the LES. So that's going to be your most definitive treatment. That's going to be a cardiomyotomy. So let's move on to distal, or was previously known as diffuse esophageal spasm. This is going to be due to impaired inhibitory innervation of the esophagus, and the peristaltic activity in the esophagus is both going to be uncoordinated and more frequent. So in normal patients, the esophagus, the peristalsis, and the esophagus is this sequential coordinated contraction which travels the length of the esophagus. But in these patients, they don't have that inhibitory innervation. So there's going to be no rhyme or reason to why the contractions are happening. It's going to be happening more frequently. It's not going to be in this coordinated fashion. So that's going to be distal esophageal spasm. And as far as history and exam, just like I went over before, dysphagia to both solids and liquids. They may have retrosternal pain. Sometimes they'll have a sensation of food being stuck in the esophagus. So that's pretty straightforward for all of these. And again, diagnosis is going to be esophageal manometry. The way that these patients are going to test positive with esophageal manometry is going to be they're going to have an increase in these premature contractions in the esophagus, primarily, of course, in the distal esophagus. So that will show a positive test. You can also do a barium esophagram. It's not going to be as good as a manometry, but it has another one of those keywords and things that you need to know. So when you do a barium esophagram in these patients, they're going to have something known as a corkscrew appearance. And again, this is another one of your key terms, and it's going to be due to the contractions. The lumen of the esophagus is going to bend back and forth, and it's going to appear like a long corkscrew. So you can see that here. That's another thing that you need to know if you see this on imaging or if it's mentioned in an exam, that you should be thinking of a distal diffuse esophageal spasm. So that's how it'll present. But normally esophageal manometry is going to be your best test, but barium esophagram is another one that you need to know as well. Treatment, like I stated before, calcium channel blockers is going to be your first line. Unlike achalasia, you don't have those more definitive, more invasive treatments. It's really just going to be medication. So calcium channel blockers, your first line, like nifedipine and those meds. And if that doesn't work, you have options like low dose tricyclic antidepressants like imipramine, Botox in refractory patients as well. But calcium channel blockers first line for distal esophageal spasm. And moving on to our last one, this is going to be known as hypercontractile esophagus, also known as jackhammer or nutcracker esophagus. So this is going to be a normal functioning esophagus, but the contractions of the peristalsis are actually high pressure, really strong peristalsis, but it's running normally. The sequence is normal. It's just much stronger than normal. So history and exam, again, very boring. Dysphagia to both solids and liquids, retrosternal chest pain, pretty straightforward. Diagnosis, surprise, esophageal manometry. And esophageal manometry is just going to show this increased strength or pressure of the esophageal contractions. Again, remember that catheter is pressure sensitive, so you'll see this increased strength. And then treatment, again, like I said before, calcium channel blockers are going to be your first line, and then your TCAs, your nitrates, Botox is going to be your second line treatment. So pretty straightforward for most of these because the diagnosis, treatment, history, and exam is all pretty similar. You just need to know those little key terms like the corkscrew appearance or the bird beak appearance or some of the causes behind them. But overall, not too much to know here. So that is going to be esophageal disorders. I hope it was helpful. Please, let me know in the comments if this is helping you. Subscribe, like the videos. I appreciate anything. I'm just trying to get the word out about these videos. So thank you so much, and good luck on your PANCE, your PANRE, your EORs, and good luck in PA school.